Good afternoon, everyone. My name is Adam Del Molino, and I am the Senior Director of Virtual Care and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's final webinar in our case management series with the Center for Case Management for 2024, entitled Utilization Review in Changing Payer Dynamics and Understanding CMS Rules and Regulations. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2024 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts to help address timely issues in case management today. I'm pleased to introduce our speaker from the Center for Case Management, Marissa Glover, LMSW. Marissa is a consultant with the Center for Case Management. With over 20 years of experience in healthcare leadership, she has honed her specialized knowledge in hospital administration and workflow, case and care management, discharge planning, and patient throughput, among other areas of expertise. Marissa has supported and provided direction to departments ranging from 5 to 125 physicians, nurses, social workers, and additional support staff. She continues to pursue her passion of patient and employee satisfaction through her work. Thank you so much for being here today, Marissa, and we're looking forward to getting our discussion started. I will hand it over to you. And I'd just like also to say thank you so much. You've done so many of our webinars this year, and I know they're really well received and appreciated. So thank you so much.
Thank you so much, Adam. Hello, everyone. Let's get started. I am going to soon share my screen so we can get the presentation up here and going. But while I do that, I want to know who I have on the phone with me. Who's here? Who's in the Zoom? If you've been to one of my presentations before, I always talk about me talking to myself. I'm an only child. I'm typically good at it, but I want to know who I'm talking to. So if you can throw in the comments where you're from, titles, disciplines, if you have other people in the room, who are they? Who's watching? I want to know who we have here. You can throw that in the comments. Hi, Cheryl. I see you checking in. And does everyone see my screen? It should be.
Yes, we can see your screen. You're good.
Perfect. Okay. I saw one person. There's one person on the couch. There we go. Katie. Who else do we have? Great. South Coast Health. Why does that sound Boston? Look, I've been there before in another capacity. Great. Yes, I would fly into Boston and then travel to South Coast. Good. All right. Just wanted to see who we have in the room. Looks like we have a lot of managers, directors of case management. As Adam previously stated, I am Marissa Glover. I'm a licensed master social worker, and I have a master's in health administration as well. I am one of those rare few unicorns that I need to stop using the term unicorn now, because there are a lot of social workers that are now directors of case management. So we are going to move forward with the utilization review. Yes, nurses, you are going to get a little insight about utilization review from a social worker. Here are our objectives for today. We're going to examine the regulatory requirements, review criteria for medical necessity, describe AI and its impact on clinical utilization review, articulate payer and hospital focus on length of care, integrate medical necessity with the 2 midnight rule, and integrate CMS regulations, and forecast future clinical utilization review changes. It sounds like a lot, but I promise I will try to make this as painless as possible for you. Updates. The only constant in life is change. And the same thing accounts for healthcare. Healthcare is ever changing and evolving due to factors such as technology, demographics, patient needs, disease patterns, political reforms, and financial tensions. We are constantly changing our process. So, for you who are on the call who don't know, federal regulations change every January 1st, with approvals occurring in October. Medical necessity guidelines, your MCG, your interqual, they change every July 1st, with previews available in March. The changes both aim to control like rising health costs, both seek to improve clinical care and quality. Regulations respond to consumer complaints, and guidelines to push more services to a lower level of care. The practices in Massachusetts I hear, I got a couple of insights, are quite different from other places throughout the US. So I will need some of your input. I want you to please ask any questions. You can ask them in real time, any anecdotal information. If Marissa, I'm not familiar with that, please throw it in the comments so we can address it in real time. Regulations. When did this all start? Of course, the Social Security Act of 1965, where Medicare and Medicaid were enacted with a fee for service payment. I don't want to insult the intelligence of everyone on the call, but I like to brag that I look a lot younger than I am, but I've been around for a long time, since the 70s. And so, under my understanding of the Social Security Act is probably different from some of you younger folk that may be on the phone that don't understand where this all started. But Medicare Part A, Medicare Part B, this kind of explains what each of those are. And because of the directors and managers on the phone, I don't know that I need to go in great detail of what Medicare provides and what Medicare does. But actually, in 1965, hospitals oversees utilization review, medical necessity, and adverse determination. We have been doing this since the beginning of Medicare. Have we been doing it effectively? Not as much. But in 1983, Medicare implemented the prospective payment PPPS system, a lot of you may be familiar with, and diagnosed related groups, DRGs, which I know a lot of you are aware of, and CMI, established observation payments for short stay patients under Medicare Part B. Now, if you all remember, this started in 1983, observation patients. It was only maybe 10, 15 years ago that we really started to pay attention to observations, but observation has been around for a long time. We just never used it as we should. Coming into 2003, Medicare Part C with Medicare Advantage insurances started, and some people say that was the turn for the worse. Other people said it's another great thing. So they're different polar opposites on managed care. Recovery audit contracts. Racks. Where are my rack survivors on the phone? Can you raise or give me a thumbs up? Do I have any rack survivors on the phone? And to my victims of racks, I'm so extremely sorry for your loss, because it was a big loss. It was a big loss. We can definitely get into the rack time. That's when we started to pay attention to observation. 2003, increased observation billing of consumers. 2004, we introduced Code 44, notifications to change patients from inpatient to observation. Are you doing those correctly? We will talk a little bit about that later. 2011 was important messages. I hope all you are doing those. 2012, financial readmission penalties for AMI, PNA, CHF, COPD, hips and knees, and cabbages. 2013, we started what some people may say the dreadful midnight rule, but it was just a little difficult to understand. But the two midnight rules started to reduce observations. 2015, Medicare outpatient observation moon started, and the moon is the Medicare outpatient observation notices. And so I am sure all of you are aware on the phone of those and are handing them out to your patients daily that are in the observation status. Medicare Advantage plans must use the two midnight for level of care. That started this year. So they have like spread it across the gamut. And talking about racks and my survivors and my dearly departed ones, RAC auditors took $925 million from hospitals in 2015 and 2016. If you didn't know the roundabout number, and I know that's probably not even the exact number, but when RAC auditors came, people were on their toes and very fearful. So thank God you survived. Thank God you've recovered. Hopefully you have changed and adjusted your practices to not get in this situation again, because RAC auditors are still out there, just not as prominent as they were in 2015 and 2016. Conditions of participation, we call them COPS. We call them the COPS at the Centers for Case Management. And this is your utilization review plan required by Medicare and CMS that every hospital who addresses and treats Medicare patients has a utilization review plan. If you do not have a utilization review plan, I suggest that you do a quick Google search on what it is and ensure that your hospital is covered and that your utilization review plan is completed. And more importantly, that you are following the rules that your utilization review plan has. You must have a utilization review committee, a utilization review staff, a utilization review process with a frequency. Typically, I think the minimum is 4 times a year, but a lot of people meet with their UR committee at least once a month. Observation code 44 process must be spelled out in your UR plan, a denial process and over-utilization review process must be spelled out in your utilization review plan. So your case managers are talking in that plan. How often are you seeing your Medicare patients? There are certain rules that the COPS provide. So make sure that you refer to your code of participation, and it's typically 42 FRF. I don't know how to make that little S thing on my computer, but if you Google it, it will definitely come up. How many of you, and I know you all are going to say this, feel as though you have a strong UR plan in place? Waves, hearts, what you call it, where you're meeting monthly or you're meeting bi-monthly, or some people meet 4 times a year. I don't know if that is as effective, but in your UR committee meetings, you should be going over length of stay. And when I was a director, we focused on the top 10. We focused on the top 10 volume admitters as far as physicians. We focused on the top 10 DRGs in our hospital. We focused on whatever we needed to do. If there were code 44s, we will ensure that we review those. If we had 5 from the previous month, we will ensure that we review those. Any really long stay patients that I wanted the team to focus on, I would try to bring a case for review every UR committee meeting to review, and so we put that level of focus to it. But that's your conditions of participation. I've been in a lot of hospitals that case managers, the directors and managers are aware of the conditions of participation, but the case managers are totally unaware. I've been in places where the case managers had no clue what the moon was because registration gives out the moon. So I want to ensure that you're educating your staff on not only what to do, but the why behind what they're doing. So let's make sure we're informing them of why their conditions of participation. Risk of the 2 midnight rules. Timing is all that matters when it comes to your 2 midnight rule. Time in the ED counts towards 2 midnights if you arrive, and it's very, very difficult. Has anyone come up with the easy way to explain 2 midnight when you're orienting your staff? I've tried to orient on this, and the only way I can explain it is if we're doing it in real time. Does anybody have a magical way of explaining the 2 midnight rule? I don't see comments. So no, it is very confusing, but it makes sense. You know, when you don't have the 2 midnights, it's not covered. So patients discharges after 1 midnight, hospital forfeits all room and board, and that's what that means, room and board payments, and you can only bill your ancillary services. Patient does not meet inpatient criteria, initiate the secondary review and the Code 44 process, provide the moon to the patient, and post-review audits and retract all payments. So that's your RAC. That's the ultimate thing that can happen, and that's your recovery audits. I'm just intrigued in knowing on the call or the Zoom here, how many of you, your case managers, are doing the UR along with the care coordination, or do you have separate UR? Just right quick, if you can entertain me on that. Are your case managers doing your UR, or do you combine separate? Oh, separate. Okay, separate. Okay. I'm going to have a follow-up question for all the separate. So for those of you, because they're centralizing UR a lot throughout the nation. I'm not saying anything is wrong with it. I'm just, is there daily communication with your UR nurse and your nurse case manager that they are communicated like, hey, this patient is no longer meeting criteria? Do you have that form of communication in place for your UR and your RNs or your nurse case manager? Not routinely. Okay, okay. I'm just noticing that because I come from old school where the case managers had, I just find it hard. How do we effectively coordinate and manage the case when we don't know the UR piece of it, when we don't know, hey, this patient is nearing not meeting medical necessity, not meeting intensity of services. Where are we at in that process? Just how do you manage that? But I'm noticing I'm going to have to adjust that this is happening in a lot of hospitals throughout the nation. But I'm kind of just on the fence about that one right now. This is your moon. For those of you who hadn't seen, this is the actual excerpt from the moon and what it's informing the patient of. I was around when the moon came out. It's written at an eighth grade level of education, so all patients can kind of understand what's going on. But I like for my case managers to further reiterate that, hey, you're in observation status. You've received your moon. Do you have any questions? Because just like most patients, they feel like they're sitting in the bed, they're in the hospital. So they don't know that observation is different, the services, the payout, until they get that bill after they've discharged from the hospital. And everybody says, I was in the hospital, I was inpatient. So ensuring that we're explaining that when they're getting medications outside of what they're actually in observation for, that they're charged for those medications. A lot of hospitals allow for them to bring those outside medications in to take while they're in the observation status. So communicating and coordinating that care is very important in your case manager's role. Pausing for questions. Any questions? Okay, we're going to keep it going. Code 44 should be far and far and few. Changes from inpatient to observations. Patients must still be in the hospital and given the moon when we're changing them from inpatient to observation. This should not be a daily occurrence. We should really be mindful when patients admit that we are getting them in the right status at the right time, whether you're using a physician advisor in-house or a third party service to ensure that these patients are meeting criteria. We want to make sure that we're careful. A lot of your CIOs are watching for code 44s. So when you tend to have too many of them, it kind of puts you on the marker and opens you up for additional auditing. So you want to be extremely careful with your code 44s, that having them, that you're getting it right on the front end. But to change from an inpatient to an obs, these things must happen. The patient must still be in the hospital and given the moon, so you can't do it after the patient's discharge. Physician enters the observation order. Physician documents agreement to the observation, and you may not bill hourly room and board charges until the order is actually placed. And the facility can bill or pre-order ancillary services like your labs, radiology, and pharmacy. You can definitely still bill for those ancillary services, but you cannot bill for room and board until the order is actually placed. Not medically necessarily. Who's utilizing their HIN privileges? Who's issuing HINs on the call, excuse me. Anybody done one within the past 3 months? I like to ask the question because I don't feel like we utilize this resource. Oh, thumbs up. Thumbs up that yes, 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 Miss Nelly. Thank you. I think this is a resource that we rarely utilize, but very, very effective. Excuse me, I'm gonna talk about what the HIN is. It's not medically necessary. The HIN is an admission or continued stay that's not medically necessary. Patient liable for 100% of the total charges. You must have an active UR committee in order to issue a HIN. So, one UR committee physician, if attending, MD agrees. Two UR committee members, if the physician attending doesn't agree. Written notification required within 2 days of the determination. Hospital issue notices of non coverage. Adverse determination equals a denial and must have a safe discharge plan. So, in those instances where the patient is refusing to leave the hospital because they don't like the place where they're going, you can definitely issue a HIN, ensuring that you have all these other things in place. For some of the physicians who are not comfortable discharging the patient because they're not pleased where they're going, or they want to hold the patient at the hospital longer to provide the care there, you can issue a HIN in those circumstances as well. So you want to make sure that you have all these things aligned before you actually issue a HIN, but it's a resource that I think we totally underutilize. Medical necessity drives the decision making process and actually required for payment and authorization for health services. In order for us to get things approved, patient has to meet medical necessity or intensity of services. And we can talk about that a little bit later about the particular entities that definitely, cover that. But payment authorizations for outpatient services, inpatient services, post-acute care services. They're used by all these subsets are used by all insurances, Medicare and Medicaid, based on evidence-based clinical guidelines. Payers may choose own guidelines for providers to follow, drives the case management decision process throughout the actual continuum. So the first one we all know, and let me pause for another question for you guys. Who's using one or both? Interqual, MCG. I'm jumping ahead of myself, but I like to know what the ideal is before I spend a lot of time talking about MCG. Who's using one? Okay, Interqual. I think Interqual. Massachusetts is big on Interqual. Yeah, Interqual. One or two of you tell me, when the insurance company uses MCG, do you have issues with your interqual? Because a lot of hospitals use both and just kind of go back and forth between the two. Yes, yeah, they go back and forth between the two. That darn Aetna pops up in any whenever I said, "Do you have any issues with payers?" Whatever it could have been, I could have said pre-authorizations, and Aetna probably would have popped up. But I find that to be different in a lot of states. But I know Massachusetts is a big interqual state. But our payers tend to take both. You may have a payer that's more MCG. Aetna is definitely one of them. So it's hard to get interqual criteria to meet that. But just to give a little background on interqual, it was started in 1978 by Joanne Lamprey, Director of Nursing, and Charles Jacob, who is from Joint Commission. It's based on severity of illness and intensity of services. I'm a social worker. When I first was forced into doing clinical work because of a mass exodus of all our nurse case managers, social workers had to do it. The way this was explained to me and the way I explained to everyone else: severity of illness, what are they here for? Intensity of services, more importantly, what are we doing for them while they're here? So that's my easy way of explaining what severity of illness is and what intensity of the clinical services is. Why are they here? Like, and then what are we doing for them? What keeps them here in the hospital? What meets hospital level of care that the patient needs to be continued stay here at this level of care? Include quality indicator checklists and discharge criteria. 2011, condition specific subsets were introduced by blending the severity of illness and intensity of service. They then started to kind of mirror MCG and started episode days added based on each actual day. You have responder and partial responder and non-responder status is included. And in 2012, they added more medical subsets and new surgery subsets with extended stay guidelines. I like Interqual, or a lot. Most of y'all are probably using Kermi or the computer-based Interqual. I'm not going to insult your intelligence. This is typically how Interqual work and conducting a medical necessity review during an episode of care. I know a lot of y'all are already familiar with how to use Interqual, and in integrating like the two midnight into that as well, because as times changes, so does interqual, so do our subsets have to change in integrating the two midnight rule. How many were told all you had to do was make this button green? That's when I first started. I don't know if you can see my mouse. Make it turn green. Make it turn green. That is not proper utilization review or legal talk. You cannot make anything turn green. But again, early in times, that's what we were told. Make it green. So hopefully, we are ensuring that the proper documentation is there, that we are applying criteria and not just making it green. Because if the patient does not meet criteria, then we need to look at other subsets, or the patient needs to be in observation, or we need to be having conversations with our physicians. More information on the two midnight rule and where you can find more information about that. And you will have a recording of this presentation if you need to go back to certain areas. MCG care guidelines. MCG actually started off as a benchmarking company. And so they took all the information, all the clinical data that they had, and added it and created their own guidelines that's really built on a lot of critical thinking, which is why you have those episodes of care. But that's the basis of MCG. A lot of payers, like Aetna, we said, uses MCG, and some back in the day, some insurance companies would toggle between both of them, but a lot of them have kind of stuck to just one now. Like most of them are Interqual, but unlike Interqual, MCG remains on the same day of the same day until the milestones are met. So even though it may be episode day 2 and the patient's been there 3 or 4 days, if nothing has changed and you're still in that episodic day of 2, you remain there until you meet requirements to progress. Observation care does not have daily milestones in MCG, so I'm not going to harp on this long because all of you literally said that you were using Interqual, but MCG guidelines are and Interqual has kind of mirrored that with their episodic care as well. So if you kind of understand that, you'll be able to jump into MCG quite easily as well. Again, this is how the daily milestones are kind of broken up in the MCG and how it looks. And they really focus on the goals of length of stay more so than Interqual does. And so ensuring that that's kind of at the top. This is how their screen looks, but they focus on length of stay on the front end. This is their two midnight rule regulations and how they integrate. And now we're going to move, because both of them now, just because of the time we're in, both offer Interqual and MCG have new AI products. Does anyone on the call have any of the AI tools from Interqual? Are we using that yet? Exolis has been around. They were actually the first to try this, to try the new AI aspect of applying artificial intelligence to Interqual and MCG. Typically, this is a cloud version of how it works. And the first issue with it is the diagnosis in the admit order is what it takes to start the actual review. Raise your hand if your physician is perfect in putting in the correct admission diagnosis at admission. Does that not change later on? I think that's one of my strikes with it. But you have to feed it the right information in order for it to produce what you need it to. But I don't know. I think it's still an issue. A lot of hospitals are not getting admit orders right on the first try. Typically, once the patient is there, it changes. But putting GI here, or I've seen broke hand, but hospitals have gotten really better about putting in a proper diagnosis at the beginning, but a lot of times it does changes. But from an AI standpoint, from Interqual, they take your diagnosis, it takes all the clinical data from the electric, I'm saying the medical record, and then it actually composes it in its own AI world, and it produces your first Interqual review. So it's supposed to save time, of course, but ensuring that the proper information is fed to it. But a lot of hospitals have started using it. I am intrigued. I have not personally used it myself, but it's definitely a resource. And I foresee us, a lot of people took time to move from the Interqual book to actually Kermi. So I think we will be integrating this AI in the very near future, and it's going to improve as time goes along, like most things do. MCG has Indencia that they use for their AI, and a lot of people like this one. A lot of people like this one better than Interqual. But again, Interqual is improving, but MCG and Indencia, like they definitely like this one better because you have a little bit more control in what the information that you're putting in. But they're competitors. Interqual will definitely catch up. Now we're going to kind of switch more. They're switching to a payer focused level of care. Payers benefits by downgrading level of care. Observations paid less than inpatient DRGs. Observation payment often capped at 24 hours. EAPG groupers for outpatient services paid less than the DRG. Patients pay higher out of pocket for observation care. Patients do not see the difference in care and check all appropriate subsets for level of care and may not meet one subset when meeting another subset. So saying all of that to talk that all levels of care matter, whether it's observation, whether it's inpatient, you want to ensure that you're progressing patients through care using, whether it's AI, whether you're using Kermi, whether you're using MCG, you want to ensure that you're using those proper guidelines to make sure that patients are at the right level of care. When people ask me for, the definition of what a case manager does, they effectively and safely move patients throughout the continuum of care. That's my quick way of saying it. That is my role as a case manager RN, a case manager social worker, or what have you, a CMA. I am effectively and safely moving patients throughout the care continuum. Because not only do I need a safe discharge, I want a sustainable discharge where my patient's not coming back a week later because I didn't solidify the discharge plan or services weren't rendered after discharge. So we want to ensure that we're mindful that we're giving safe and sustainable discharges. Back to levels of care here. You can't take the social worker out me ever. Payers seek to approve at the lowest level of care. Now, if you're a payer, does that not make sense? So ICU to intermediate care, and these are general numbers. They're not specific to, your hospital or Massachusetts, but just a general idea of how these numbers tend to look for room and board for intensive care units, which tend to kind of run 6,800. And then on your NICU levels, you see it actually goes up depending on the level in which the patient is in there, which makes sense because the services are probably far more greater at a level 4 room and board for newborn. Payers fail claims for mismatch authorizations. So if your payer is requiring you to get authorization for a level of care, and then that patient doesn't meet that level of care, they're going to pay at the level of care that they authorize. So, in a lot of your hospitals and organizations where your physicians don't necessarily agree that a patient needs to step down for an ICU unit because they like the care that they're receiving on that ICU unit and they don't want to step them down to a GPU, med surg, whatever you call it in your organization. In those cases, the payer is still going to pay out as though that patient was in the lowest level of care, no matter where you have them in the hospital. So you just want to be mindful of that and understand that you're losing money on the back end. That's another thing I have to say about case management that a lot of people don't. We are a financial arm to the hospital. We are a caring, quality department, and we care about our patients, but we're also the people who help bring in the proper utilization of resources and monies into the hospital by the way we track and keep our patients safe. And we know the intensity of service for why they're here. We know the severity of illness of why they're here. And we report that information to insurance companies. I know a lot of y'all, like the UR does that, but it's our role as the case manager to ensure that we're coordinating that and that we're not over or underutilizing resources that the hospital is paying for. So if your UR department is saying, hey, this patient is, the insurance company is only paying for a GPU, somehow that has to be communicated to the case manager that's covering that ICU unit so she can communicate to the physician, hey, we're no longer getting paid at an ICU rate. The physician's going like, I don't care, this is where I want my patients, this is the best care for my patient at that time. But it's ideal for that to be communicated. You've done your role, you've done your job when you've communicated that to the physician. And then for me, that's an avoidable day, the ICU, where that patient could have been at a lower level of care. It's a full cycle here. It's a full cycle. Payers integrating the two midnight rule. We talked about in 2024, Medicare and Medicaid Advantage plans must follow Medicaid. And this, I just noticed that they did put Medicare, Medicaid, Medicare together, but they must follow the same plans for the two midnight rules. They may use medical necessity guidelines as they have in the past. Commercial insurances only use medical necessity guidelines, which is going to be more along your lines of interqual. Validate the rule. Oh gosh, applicability. There you go. Your payer contracting and payer. Two midnight rule must support reasonable expectations of a two midnight hospital stay. Have clinical documentation justifying this expectation. Use of a plan that will reasonably take the two midnight hospital stay. All of the above must be present at the time of admission of when the order was written. Has anyone on the call experienced a nursing home sending a patient back because they didn't meet the two midnight requirement? Because it trickles down to them. Has anyone ever experienced that? Because I definitely have. Or the two midnight rule, they, especially in the beginning when it started, we dealt with a lot of same day in the readmissions because the two midnight rule wasn't met. So you want to ensure that you're mindful of that. And it's so funny, somebody brought up Aetna, and of course we're using them as an example. But our MA plans to follow the two midnight benchmarking rule. Aetna is very particular about the two midnight room, and plans aren't required to follow the two midnight presumption with Aetna. So good or bad, you got to adjust to whatever Aetna is kind of asking, and they want retrospective reviews and denials as well for their medical necessities. And I think this is just specific to Massachusetts. So and it could be throughout. I need to double check that. Has anyone heard of this as far as Aetna utilization management and prior authorizations? I think and I need to take a moment because I just shared this information with the Massachusetts Hospital Association for hosting this but also being a great part of your governor overturning the need for pre-authorizations for insurances in your area. I've been told, and I could be wrong, y'all correct me if I'm wrong, that your payers have to turn over your pre-authorizations within 24 hours. That is a major feat. I am currently in Detroit right now, that I just left a patient progression round where they've been waiting 3 days for authorization. So hearing that your governor is overturning that rule of waiting that long and they have to turn them over in 24 hours, kudos to MHA for that. Does yeah, well no, yeah, it's during the week when they're there, but it has to be 24 hours. Can someone answer her question? Does that include weekends? I just read the general rule, the nuances behind it, I'm unsure of. But for my Massachusetts folks on the phone, does that include weekends that it needs to be 24 hours, or is that a weekday? One of our viewers are asking. So if you know that answer, please just throw it in there. But I do know that it's 24 hours. I'm going to say business hours is probably what they're saying, but it's even better if it covers the weekends as well. This is the Medicare denial process. It's spelled out in the utilization review plan. A lot of you said that you're doing your UR separately, so this doesn't necessarily fall in your lap. But how many of you have active physician advisors that's kind of helping with these determinations, whether it's a third party, R1, Optima, if it's any of those? Do any of you have any physician advisors or your own physician advisor? Amazing. And I think I actually just, yeah, spelled like, and in Massachusetts, you guys are the only, I found this really interesting, that you have a private review agent spelled out. It's a private review agent that's licensed in the state, telephone notifications within 24 hours of denial, written and electronic notification within 1 working day, copy of the relevant guideline provided upon request. Provider can initiate the appeal via telephone, write to the review with a practitioner of the same school as an ordering provider on an expedited basis, and written appeals must be due within 30 days. You guys can do like a very quick, for your denials process, your physicians can do it in real time. And I don't know if anybody has ever dealt with like doing a denial, they call it a peer-to-peer with a physician. A lot of times, if I'm a cardiologist, I'm in the hospital and I'm trying to fight a case, they'll put me on the phone with a gynecologist, a pediatrician. It's just whoever's available. In the state of Massachusetts, you can specify, nope, I want to talk to a fellow cardiologist so I can have a conversation and really have a fair chance in fighting my case and they understanding the terminology or the care that I'm trying to provide. So again, kudos to Massachusetts for taking that on too. Okay, looking ahead, and we are about to wrap this up. Regulators will focus on payer prior authorizations. We talked about just now the Massachusetts governor signed an act to improve quality and oversight of long-term care. This is a 2-year pilot for next day. Look at this, it was right here. Next day prior authorizations determination for post-acute facility placements, 7 days a week. Payers will focus on increased denials to offset increased administrative costs 7 days a week. More down leveling of care, retrospective. We still wait for the off. Look, I'm gonna check the dates of when this started. Retrospective denials for Medicare Advantage short stays, expanded readmission denials. What I would say, guys, is screenshot this page. Screenshot this page. It's the sign, it's the Act to Improve Quality and Oversight of Long-Term Care. Pull it up, read it, so you'll have an effective weapon to speak from. And then I'm sure MHA on the line, they may have some feedback on this as well, but you definitely want to ensure that you're not waiting for us, because per your governor, you should not be. So let's just see the time frame of when it starts. All slides. Okay. I was trying to catch that other let me jump to the chat right here. It doesn't mess up anything on my end. We still wait 72 hours for some pay. Yeah, see, that's the issue that they're having in the rest of the the US. But this is very clear, so I urge you to go do a little further research on this to ensure that this is happening. Because this is just implemented, and I mean, like the dates I almost want to say it could have been October 1st. So you want to follow up and ensure that this is implemented into your hospital. So if you don't walk away with anything today, walking away with this information, and we are clear this is 7 days a week they should be providing authorization. Take this information and run with it. Any other questions from the group? I'm going to pause and see, is there anything else you need to know or want more information on? UR is really interesting, and the fact that a lot of you have it separate and a lot of you are still kind of focusing more on the care coordination case management side. I think that understanding the utilization review and the CMS guidelines, especially the codes of participation, which we call COPS, is ideal to run an effective department where you're ensuring that all your bases are covered. UR plans, ensuring that you have an updated one. I was at a hospital doing an assessment before, and their UR plan was 4 years old. They should be updated. It says in the conditions of participation, it's either 1 year, 2 years, or 1 year. I can't now. Don't quote me on that, but go to the conditions of participation and pull it up. It should be updated in a timely fashion, but not be 4 years old. Still pausing for questions. Okay, I am going to turn it back over to our fearless community of leaders at the Massachusetts Health Association.
Well, thank you so much, Marissa. This has been a lot of information, and I appreciate your guidance and discussion and reminding folks to to look to some places. And there are some resources here, and as you mentioned, and I posted in the chat, this recording and slides will be sent to everyone who's attended today. So to your point, have for reference. And again, just want to thank you for all of your participation, many of our series throughout this year. It's been really valuable. We've gotten great feedback. I know the folks on the discussion today as well. So wanted to thank you. And for those who are attending live and those who are watching later, really appreciate your interaction and engagement with this and topics. And we look forward to sharing more with you all next year.
Great. Thank you.
Thank you. Have a great afternoon.
You do the same, everyone.